It's July 2003. We're in Madrid, Spain, at the ESHRE conference. Next to me, Dr. Kolibianakis. Very welcome.
Thank you.
You're originally from Crete, Greece, and now you're working at the Free University in Belgium, Brussels. You presented this meeting about timing of HCG in IVF and ICSI as well, or?
Yes, it was IVF and ICSI cycles.
IVF, ICSI cycles. Why did you do this research? Why do you think this is an interesting question, the timing of HCG?
There are several reasons. If you look at the literature, first of all, you will see a marked discrepancy in the criteria used for HCG administration. And in medicine in general, if you see a disease that has too many treatments, probably you come with the conclusion that there is no effective treatment. So, seeing that there are so many criteria for HCG administration, probably it means that we don't have a solid basis on which to establish this criteria. And if you search in the literature, you will see that this is true. So that's one. Secondly, if you look more carefully to this criteria, you will see that they are not strict criteria. So in almost all of the criteria used, you will see the word "at least" when this criterion is met, which means in fact that you can give HCG when you reach, for example, 3 follicles of 17 mm, but you don't have to do that necessarily. You can go for 1 or 2 days more. And I think this is a source of problems. So we have to define what is the best criteria to use for HCG administration, and certainly to use strict criteria. So that's the one approach to the problem. The other, which is less obvious, comes from our work in the last 2-3 years on endometrium. So if you look at endometrium, histology of endometrium at oocyte pickup, you will see a universal picture of advancement of endometrium, which means secretory changes, in almost all cycles. Either you use analogs, antagonists or agonists, or even in non-analog cycles. This means that there are events occurring in the follicular phase that lead to this picture. We have shown in last November in a paper published in Fertility Sterility that this endometrial advancement, if it goes to the extreme, so more than 3 days compared to the expected chronological date, leads to a significantly lower ongoing pregnancy rate. So the next thing to consider is what can we do to alter this picture. So you have to think how secretory changes occur. In the natural cycle, it is well established that this occurs through progesterone action. Progesterone acts on progesterone receptors, which are induced by estradiol, and this is established knowledge. In the hyperstimulated cycle, unfortunately there are no receptor kinetics, but you have to assume, because of the several times higher estradiol levels and much earlier in the follicular phase, that probably this phenomenon occur much earlier, and by the time of oocyte pickup they lead to advancement.
Okay, so you make clear that it's, the timing may be an important factor. Which protocols did you use in your research?
So we decided to go for recombinant FSH and an administration of antagonist on day 6 of stimulation. We used Puridone and Orgalutran.
Okay. And then how did you make your 2 groups?
Right. So the idea is that you have to reach a certain criteria for follicular development. In this study, we decided to go for 3 follicles of 17 mm, which is arbitrary on the one hand. On the other hand, it is a criterion used in almost all comparative studies between agonists and antagonists, so phase 3 studies. So it was a good starting point, we thought. So as soon as the patient, which means of course that you have to do several ultrasounds to confirm that. So as soon as the patient has 3 follicles of 17 mm, HCG is administered. In the one arm, and in the other arm, as soon as this criterion is met, you prolong the follicular phase for 2 days later, without considering at all estradiol levels, which however you measure.
So, without measuring the estradiol levels, so
with measuring estradiol levels, but not considering them in your decision.
Oh, I see. Yes. How big were your two arms?
So the study is now finished, and in each arm there was 208 and 205 patients randomized.
That's a rather big group, yes. And, well, the results.
Sorry?
And the results.
The results.
Okay.
The result is that there is a difference between the early and the late group of ESHRE administration in ongoing pregnancy rate and implantation rate, and this means that there is a higher, significantly higher pregnancy rate, ongoing pregnancy rate in the early ESHRE group. The difference is about 10% if we talk about ongoing pregnancy rate per oocyte pickup. And it's also about 8% in implantation rate.
And what were the ages of these women?
So the criteria we use for selection of population were broad criteria, so this really is an unselected population. This poses some problems in terms that your randomization may fail, which was not the case as I presented, but on the other hand the results are much more applicable. So you should expect that if you repeat the study in again a broad population, your results will be the same. So it's not talking about a certain group of patients.
I see. And
so less than 39 years of age was the answer to your question.
Yes. Okay. So the results are better in the early group in terms of pregnancy rate. Were there any differences in women you had to cancel the cycle because of hyperstimulation?
No, there were two patients in each group that we had to give agonist instead of ESHRE because we thought it was unethical to continue with ESHRE. But it was the same to two patients, a very small number in both groups.
So this was indeed.
But you would expect theoretically that you may have a little bit more hyperstimulation in the late ESHRE group, and this was indeed the case. So it was about 3 to 5%, 3 in the early group and 5% in the late group. Not severe cases though.
Okay. So concluding, it seems better not to wait too long after you have 3 follicles of 70.
I think it's what is really an important message for this study is that whatever study you do, you have to use strict criteria. Otherwise, your conclusion, and we have seen a lot of papers in this Congress talking about relationships of age to outcome, that if you use loose criteria, all your results are in doubt. So whatever criteria you use, it should be strict. Now, this study suggests that by taking an arbitrary, from our point of view, again arbitrary, criterion of 3 follicles of 17 millimeter, if you prolong the follicular phase, you will have worse results. And this is in contrast to the popular belief that bigger and follicles and more follicles are associated with a better outcome.
Did you have any difference in the quality of the eggs you harvested?
So the quality of the transferred embryos and eggs, according to all tubular-oocyte complexes and according to the established criteria used in vitro fertilization, did not differ. This suggests that the difference may not be due to an embryonic factor. Fertilization rate was the same, but of course there are more criteria, more sophisticated. But I'm talking about the established criteria that we use each day in everyday practice to distinguish between the embryos to be transferred and those that are not going to be transferred. So with this evaluation, no suggestion of an embryonic factor is present. So we think, and we try actually to assess that now by a prospective randomized study on endometrium quality, that this is really an effect mainly due to an endometrium factor.
Thank you very much.
Thank you. It was a pleasure.